Platelets. When do we care about platelets? We care about platelets when they aren't there. Our severely thrombocytopenic patients, right? And before we can identify that something is not there, we need to make sure we know what it looks like when it is there. So step one with our platelet review is we're going to refresh our memories as to what platelets look like. Platelets are small cytoplasmic fragments. If we remember, they come off these huge megakaryocytes in the bone marrow that extend these proplatelet processes through the endothelium and shear off little bits of that cytoplasm. And in that cytoplasmic fragment are a ton of granules. So what we are looking for little round things typically, usually smaller than an erythrocyte, but not always, with little purple granules in them, like kind of that pale blue cytoplasm, purple granules, no nucleus. That's what we're looking for in these patients. Okay, so let's go ahead and take a tour. All right, looking at our different species and what platelets look like, and there's subtle variation between them. For the most part, they look pretty similar, but we'll just take a quick peek here. With a little more emphasis on dogs and cats, because I think that's mostly when you're going to be checking for platelets in our animals, sometimes horses. So in our canine patients, very much as we described, they're cytoplasmic fragments, no nucleus. So you see this sort of blue cytoplasm here, and chock full of purple dot granules. Some of them have more granules than others, depending upon like what broke off of that megakaryocyte. But pretty uniform size as we tour through here. Our feline patients, similar appearance. They can have a little more size variation than our canine patients. One of the things that happens with felines that's feline specific is their platelets tend to be a little more sensitive, and they will activate on the negative charge of the glass that we spread our blood film across of. So our felines, we can sometimes see their filopodia sticking out of their platelets, and a little more size variation in those guys. Equine platelets, when we're looking at our horses, they tend to be a little more pale than our dogs and cats. Can take actually in some instances a little more time for them to come out from the background to be able to pick them up. So this particular picture, they're softer than what we were seeing in the dog and the cat, but they're still able to be picked out. I have in this particular image, a clump of them. We're going to be looking at platelet clumps in just a minute, and this patient had quite a few of them. For our bovids, they tend to have very small platelets, little itty bitty dots. Just like they have small red cells, they have small platelets. They'll have more of them than we normally see in our dogs, cats, and horses. So they make up for that small size by increasing the number of them to ultimately keep the same amount of volume that's in circulation. So now that we know what platelets look like, where do we find them? We're going to be looking for two places within the blood film to evaluate platelets. The first place that we're going to look at is we're going to do a low power scan along that feathered edge at the far end of the blood film. We're going to be doing this at 10x. Okay, so it's a nice little efficient cruise down that edge looking for globs of platelets. And what do you suppose globs of platelets would look like? Clumps of platelets look like that sort of pale blue with purple bit dots in there. You'll pick up at lower power more of the pale blue to them. And as you come across things, if you aren't sure what it is, go up to high power and take a peek. So for example, I have a nice little high power view here of our friend from our horse that we were just looking at, who had platelet clumps along the feathered edge. And you can see they're all kind of stuck together in just sort of one little layer. So why do we care about platelet clumps? This is a question for you guys. Do they mimic leukemia on our CBC analyzer? So when we get platelet clumps back, we don't know if maybe this could be a leukemic patient. Do they falsely increase your platelet count? Or do they falsely decrease your platelet count? Quick review. What do you think? So for those of you who answered, they falsely decrease your platelet count, you are absolutely right. Aha, bravo, well done. So yeah, they falsely decrease your platelet count. So how the analyzers will work is they evaluate platelets based on their size. And when they clump together in these things, they will come across as being larger in size. And depending upon your analyzer, they'll be counted as one of three things. They'll either be counted as larger platelets, if the clumps aren't too big. They'll get caught in the red cell category, or they'll get caught in the lymphocyte category. One of those three options there. There isn't enough platelet clumps in any given patient to impact your red cell or lymphocyte counts. Once in a while, maybe your lymphocyte count might be a little bit up. Red cell is definitely not an issue there. And it depends upon your analyzer type as to where they end up categorized. But it's important because we're talking about thrombocytopenic patients, right? So we get this blood count back from our analyzer that says our platelet count is low. The first thing we want to do is make sure it's not because they're clumped. Clumping's super common. It happens all the time, especially in cats. They are professional platelet clumpers, and can sometimes give you those falsely decreased numbers. So step one, we're going to look for the feathered edge, and we're going to look to see platelet clumps there. If we see a whole bunch of clumps there, you know that what you have on your analyzer report is a minimum platelet count. Meaning at minimum, they have XYZ number of platelets, right? The second place we're going to go to look for platelets is we're going to look in the monolayer, and a very specific part of the monolayer. We're going in to the deeper end of it. We want to be in the area where the red cells are just beginning to think about overlapping a little bit. We may see one or two overlapped red blood cells within our space there. And at that sort of level of the blood smear, we are going to take a look around and do a platelet estimate. So there's a couple of different ways that we can do a platelet estimate. The formal way of doing it is that you take this area where they're just starting to overlap, you count all the number of platelets in 10 different fields, you take the average, you multiply it by 15, and that gives you a platelet estimate. There's a quick and dirty way to go about doing this, and that is knowing what your minimum platelet count should be, which is around 100,000 for our small animals, and our equids can go down even a little bit lower than that. So when we look at these fields, rather than counting and recording 10 fields and taking an average and multiplying it by 15, you want to make sure there's at least 7 to 10 for our small animal patients in that field. For our equids, 4 to 7. In that same range, we're going to cruise around there and make sure. Okay, let's practice an example. I have an image here that we're going to pretend is what we're seeing through our microscope as a high power field. Can't capture the entire high power field on a microscope camera, so we're just going to use our imagination here. What we have in this particular field, and we can see that it's an anemic patient. We're a little bit farther into the depth of field. You can see here where there's a little bit of red cell overlap, just a little bit. They're just starting to touch, and this is where we want to be looking. So we're going to practice going through this field. When I'm looking here, I see 8 platelets. So 1, 2, 3, and 4. They're right next to each other. That fourth one's kind of overlapped on the red blood cells. 5, 6, 7, and 8. Okay, total of 8. So how are we going to do this? Well, one of two ways. We can take that 8, multiply it by 15, get our 120,000, or we can just say, hey, it's a small animal. I want it to be at least between about 7 to 10 per high power field. Great. We're at 8, right in that range. Piece of cake, moving on with life. So that is sort of the quick and dirty on how to do a platelet estimate. Let's practice a case. So we have an adult dog running through our platelet analyzer, and we've got back a total of 3 times 10 to the third per microliter, so 3,000 platelets per microliter. And our reference interval is 140 to 350,000. So severe thrombocytopenia, if this is real. Where are we going to go to check? Well, first on the blood smear, we're going to come down and scan that feathered edge. So just cruise right on down that puppy. And suffice it to say, there are no platelet clumps here. Next, we're going to come back deeper into the blood film, and so farther that back end of the monolayer, and we're going to come in here and take a look, and we're going to count a whole bunch of fields to make sure there aren't any platelets there. For this example, we're just going to go through 5. So we've got this one, no platelets. This one, I don't see any platelets here either. How about this one? Nope. 4th field? No. 5th field? Still no platelets. So not a platelet to be seen. Like the tumbleweeds are rolling by. We aren't seeing any platelets here. So is this really a platelet count of 3,000? Yeah, this is what it will look like on a blood film. Severe thrombocytopenia. You know what platelets look like. Don't be fooled by other stuff. Trust your guts. So there you go. Before we move on, quick platelet recap. Done lots of platelet stuff. They are small, anucleate, cytoplasmic fragments full of little granules. We are interested in them mainly when there's a thrombocytopenia. Our first question is it real? Are there platelet clumps along that feathered edge? And then if they are not there, then we can go back farther into the smear and look at the deep end of the monolayer and see if there are any platelets present there. We know how to estimate platelets. We can do it with the mathematical equation, or we can just do our shortcut of there should be at least 7 to 10 per high power field in our small animals and 4 to 7 per high power field in our equids. All right, that wraps it up. Let's move on. Regenerative anemias, here we come. So our next topic is going to be looking at regenerative anemias. Regenerative anemias are important because they're typically caused by one of 2 things, either hemorrhage or hemolysis, both of which we like to intervene earlier rather than later with our patients. There's a couple of key things that we're going to be looking for to identify a regenerative anemia and then also to figure out the underlying cause of that regenerative anemia. The first being that we're going to start with our analyzer data. And there are 3 big things that we're going to look for on our CBC data. 2 of the 3 we will probably have on our in-house analyzers. The third one, maybe not. The first being our MCV, or mean cell volume. Our polychromatophils, or our reticulocytes, are larger than our mature red blood cells. So when that mean cell volume, that mean cell size starts increasing, it indicates a regenerative anemia. The next one being our mean cell hemoglobin concentration, or our MCHC. And our MCHC looks at the amount of hemoglobin that each of our cells are carrying around on an average. Our younger red blood cells haven't finished making all their hemoglobin, so they tend to have decreased mean cell hemoglobin concentrations. So far we've got an increased MCV and a decreased MCHC. Our best indicator of whether or not an anemia is regenerative is to look at our reticulocytes. And not every analyzer counts reticulocytes. Usually that is something where you need to send it off to a laboratory to get a retic count. But we can pick up on reticulocytes on our blood film, which is where blood film becomes important. Keeping in mind that when we're looking at this analyzer data, the mean cell volume and the mean cell hemoglobin concentration, those are averages. They're not, they're looking at the whole population, and there's a reference interval of normal, and it takes a fair amount of change to push an average population outside that reference interval. We can pick up on polychromatophilia or reticulocytosis on our blood films a little bit earlier sometimes than we can on our analyzer data. So this is one reason to pop on a blood film. Where are we going to be looking for these? We're going straight into the monolayer, and we're looking for what we call on blood films polychromatophils. You'll hear me use polychromatophil and reticulocyte interchangeably here. For our purposes, they mean basically the same thing. On the blood films, they look like these larger lavender erythrocytes. And we can see we've got several in this particular image here. Why are they called polychromatophils? Poly meaning many, chroma meaning color, phil meaning love. Okay, so many color loves. Our dyes are red and blue, and when they are mixed together and picked up together, we get these pretty lavender shades or purple shades. And this is where polychromatophils are. So, polychromatophils, reticulocytes. We're looking for an increased number of those. There's some species differences, but for the most part, if you're seeing 1 to 2 per high powered field or more, you're probably have an increase in polychromatophils and a regenerative anemia developing. So the other reason you may want to put your eyes on a blood film is if you happen to have a patient that has a number of polychromatophils present that are larger, but maybe also has a number of smaller red blood cells. For example, like early iron deficiency patients, they may have a number of microcytes as well as a number of polychromatophils present. And when we look at our mean, our average of that, it ends up coming down right down the middle. So it does behoove you to take a peek and make sure that you are seeing those polys there and that it does look like a regenerative anemia. And while we're there, while we're looking at these slides, we're going to also check the red cell morphology for a couple key changes that may give us a clue as to what's going on and causing that regenerative anemia. Okay, spherocytes. Let's start there. They're such a classic, and I think they are totally cringeable. I'm here to tell you a couple of things. One, where to look for them on the blood film, because there's some places where there can be some doppelgangers out there, and give you a couple tips on how to identify them. And then I'm going to tell you that they're a really challenging morphology to identify. They challenge sometimes even clinical pathologists. And if you think they are there, get yourself some backup. Always send that one out for a slide review. Okay, so we have a blood film with a massively regenerative anemia and maybe an icteric patient, and we're thinking, is this IMHA? Is this what's going on here? When you look at that blood film, there's a couple things we're going to be looking for. The first being from like very low power, we're going to be looking for agglutination. You may or may not see it. I think more commonly I see agglutination actually on the macro level on the slide, in the tubes themselves. Anytime you see that or you think you're seeing agglutination, you want to make sure you do a slide dilution test. So 1 drop of blood, 3 drops of saline at minimum. You hear anything between 1 to 4 and 1 to 10. Both of those are totally acceptable for dilution and will help give you an idea of whether or not those are truly agglutinating or if they're actually just stuck to each other doing like a rouleau thing. So let's pretend that we've our index suspicion is high and we're looking at our blood film and we really want to see if there's spherocytes here. The first place I want you to do is move to the deep end of the monolayer, okay? There's a spot in that monolayer towards the front where there's like false spherocyte formation. It's just how the red cells spread out, and it usually happens like just before they start moving into that feathered edge. So you want to look deeper into the monolayer, and not super deep where you're starting to move into like body of the smear territory, but the back end of the monolayer, and cruise around there. What we're looking for is we are looking for a normal red cell. Haha, surprised you, didn't I? Yeah, no, we're looking for a nice normal red cell, one that we are totally convinced is in this patient. So let's say, and let's limit this to our dogs, okay? So we're looking for a red cell that's got that nice central pallor, because the dogs have red cells big enough that they can spread out, that when they're on the smear, that like sort of elliptical center to them is a little bit thinner, so they get that little central pallor. One that we're like, this looks like a real red cell, and an appropriately sized one. In dogs, and only dogs, okay, only dogs, you can use a nice, well-differentiated small lymphocyte. Okay, these are the guys with the round cells, mostly nucleus. Okay, that's really well condensed. A nice mature one of those. You can use that as a micrometer for your red cell. The nucleus of that should be about the same size as the red blood cell. Find your one that you're like, this is normal, I'm happy and I'm comfortable with this. That's your first thing. Then we're going to look around it. Are there cells there that are like half to a third of its size, perfectly round and super dense? Most of them are super dense. Once in a while, you might see a little like there can be some forms that'll trick you, but go for the classic. Okay, is it perfectly round? Is it super dense? Those are your spherocytes. Okay, you can usually see them on 3 dimensions. So if you fine focus and up and down with your scope, you can kind of even move a little bit through the layers there. But that's what we're looking for. Nice normal red cell, normal size. We're looking for something like a spherocyte around it. You're convinced you have a spherocyte, hopefully multiple spherocytes. Things are adding up in your mind that this patient might be IMHA. I just caution you to make sure you back yourself up with this. Send it out to have either a clinical pathologist or one of the laboratories review the slide just to back yourself up, and go ahead and move forward with things. So it takes some practice. Remember, this is one that it's going to take a little bit of time, but the trick in my mind is find normal and look around it. And those spheres are small, dense, tiny. Weird ClinPath quirk about spherocytes. Some of us don't call them unless it's a dog. That's the way I was trained. There's a good number of us that won't call them unless this patient is specifically a dog. So why? The dog has bigger erythrocytes. It has that lovely central pallor. We're using a normal to compare to. They look small and dense. We can sometimes see that same morphology on our cats, horses, ruminants, camelids, et cetera, with smaller erythrocytes, and can't call it unless we might call them microcytes rather than spherocytes. It's mainly because the dog has that central pallor and we have that nice comparison. So use it. Okay, another somewhat alarming cell morphology is schistocytes. I was at a lecture with a former emergency clinician who currently runs a big diagnostic lab, and he used the term schistomypansocytes. When you see them, you're going, ah! And touche, my friend. Very true. It's a favorite, I think, because they're pretty easy to recognize on a blood film. So we're looking for fragments of red cells. Schistocytes happen when red cells have been sheared or fallen apart. Okay. The classical example of their morphology that I look for on blood films is look for little mice or rats. They're going to be like chunks of red blood cells, but a lot of times they have this like sort of shape where you can almost be like, that's a nose, that's a body, look at the tail. So think about that. It was kind of a fun one that sort of helped me learn how to recognize them. And so what happens when they show up? We're thinking about 3 big mechanisms with them. So first being fibrin deposition, and probably the most classical that we go to, schistocytes, DIC. Remember that DIC is a syndrome and it's a comorbidity, and these patients are very, very sick. So if it makes clinical sense, throw that in your back pocket. Another time we see them, that is another classical finding, is hemangiosarcomas. So splenic tumors. And the mechanism for this is vascular turbulence. So these red cells, remembering that hemangiosarcoma, hemangio being blood, it is a tumor of the endothelium, and it makes all these funky sort of weird routes that the red blood cells are getting whipped through as they move through the spleen. And they run into walls and they get torn around corners, and it causes them to break and fall apart. So hemangiosarc, vascular turbulence in general, is another one that we throw in our back pocket. The last sort of big mechanism here is erythrocyte instability. So this is erythrocytes with a little overlap with like vascular turbulence, but this is more when the erythrocytes aren't completely developed and aren't completely stable. The big example that I use for this is iron deficiency anemias. Schistocytes can be seen on there, as well as a lot of variation in red cell shapes. Sometimes they are, sometimes they aren't. Like sometimes you get a lot of that variation, or poikilocytosis. the sort of short fun term is POIC. Do we have a lot of POIC here? But they can be seen with iron deficiency, along with some other morphologies that we see with fragmentation, like acanthocytes and keratocytes, which we're not going to dive into. The big one being erythrocyte instability. Come back to your patient again. Those are the things to think about when you see a schistocyte. All right. DIC, hemangiosarcoma, maybe iron deficiency. Are there other causes? Sure, just not super common with this one. So there you go. The last morphology I want to touch on is Heinz bodies. Now we will note that there are a couple bodies that we find in erythrocytes that both start with H, our Heinz bodies and our Howell-Jolly bodies. So how do we keep these straight? They're very different things, right? Our Heinz bodies are indicative of oxidative injury, and they're the erythrocytes with the little precipitated hemoglobin on top that makes like a little, almost like bud off of it. And our Howell-Jolly bodies, which is a nuclear remnant in the erythrocyte. This is how I remember Heinz bodies specifically. We've got our erythrocyte, and it's got this little puckering top to it. If you look at the Heinz tomato ketchup bottles, the classical ones, one of their logos is a tomato on a vine, right? So it's got this little round tomato, and it's got this little green top to it that's hanging off of the vine. So imagine that, like you're looking at this erythrocyte. Could you turn it into a tomato with a green little thing going from that nice pink with like that slightly pale lavender top to it over to a red tomato with a little green top to it? So Heinz ketchup, I don't know. It's how I remember it, and it's how I've gotten students to get it into their head. So there you go, just for fun. So how do these guys form? They're actually precipitated hemoglobin. And remembering that our erythrocytes, our red cells, are just stocked up with tons and tons and tons of hemoglobin molecules in each erythrocyte. Our hemoglobin molecules have on them these self-hydryl groups. And when they're oxidized, they precipitate. They clump together and precipitate. And they form these little Heinz bodies that are these little puckering edges. So we're thinking oxidative injury with these patients and our classic toxins that are associated with it. So in dogs, garlic and onions, and then zinc from pennies are sort of the classical ones. Knowing that there's a long list of these, like cats, acetaminophen, horses, wilted red maple leaves, brassicas plants and the species of plants, cabbages and kales in our cattle, and so on and such forth. Very long lists of these. But it kind of gives you an idea when you find this that maybe there is a toxin going on. Besides oxidative injury from a toxin, there's a couple other diseases to keep in mind that can sometimes show up with Heinz bodies, especially in cats. Hyperthyroidism being the first one. Diabetic ketoacidosis is another one when we'll see Heinz bodies. And the last being occasionally in some lymphomas, they'll pop up. Now these guys in the disease categories, they tend not to be overtly hemolytic. So it's slightly different than the toxin ones that can break into a hemolytic anemia and cause a great deal of damage, anemia, icterus, et cetera, et cetera. These guys, generally speaking, aren't as profoundly hemolytic. So the presence of Heinz bodies really narrows down your list. All right, so toxins versus one of those three diseases. Useful little morphology, isn't it? And just for fun, one other morphology that sometimes shows up and can show up fairly commonly with Heinz bodies is eccentrocytes. Eccentrocytes. I love them because they're eccentric, right? Just like me. What ends up happening in these cells is hemoglobin will shift to one side of the cell, and it leaves like the cell membrane kind of folds and collapses on itself, and it leaves this very clear little sort of half moon shape, not even half moon, little moon shape on the side of them. They're indicative of oxidative injury as well, and we'll sometimes see them when Heinz bodies are showing up. So the presence of either or of these narrows down your list to toxins, and then Heinz bodies in particular, you want to be thinking about those three diseases: hyperthyroidism, DKA, lymphoma. Piece of cake, right? So helpful and so cute. Okay, you guys still with me? Our last topic that we're going to touch on is leukocytosis. And I'd like to take just a minute here to sort of take a step back and think about when we see a high white cell count. And I'm not just talking like your average little mild, maybe a moderate increase in white cells. I'm talking about a leukocytosis. So here's the deal with our analyzers. They're really good at doing reliable differentials when our patients are healthy and our cells have their normal morphology. So they're really good at shuffling them into the right categories. When they don't do so well is when we have cells that shouldn't be there, or we have cells that are undergoing morphologic changes, like our neutrophils when they become toxic, when there's massive inflammation going on. What I think about being able to identify a mature neutrophil where that becomes particularly helpful is when you're looking at your blood film and thinking to yourself, is this white cell count really that increased? And is this mostly neutrophils, or is this mostly something else? So when we look at this, and the reason I do that particular distinction of is this mostly neutrophils or is it mostly something else, is that it's going to send us down two different diagnostic pathways, I think, as well as adjust our conversations with our owners. If we have a sample that has a high white cell count and we put eyeballs on that blood film and we're just scanning around going, yep, there's a lot of white cells here, and yep, they're mostly neutrophils, what comes to mind is inflammation. And we're going to be moving down a slightly different track with our patients, trying to rule out inflammatory disease, or at least a starting point there. If we look at that blood film and we're like, there's a lot of cells here, a lot of nucleated cells here, and they're not all neutrophils, there's a lot of somebody else here, you're definitely going to be having a slightly different conversation with your owner. Like, there's some kind of fishy cells on here. We're going to be thinking about inflammation, but I really want to get a path review on this particular slide. So what can we do to move our diagnostics along a little bit faster by using a blood film in these cases? And what I would encourage you to do is to start getting comfortable with what a neutrophil looks like. Neutrophil. These cells, they're round cells, okay, and they've got neutral cytoplasm. They should be pretty close to the background of your smear, at least in healthy animals. They've got pale pink granules, which you may or may not see. They're not like eosinophils that are like, whoa, smack you in the face, red orange huge granules. They're very more subtle. And they've got this nice segmented nucleus that is really condensed with condensed nuclear chromatin on it. One of the things, by being able to identify a neutrophil and say, hey, that's what the majority of this population is here, that allows us to say, well, we're going to at least start the hunt for inflammation. And we're gonna put that up higher on the list. We're still gonna be sending that CBC off for confirmation and a second opinion and make sure that we haven't missed anything. But at least you can come back to the client and say, hey, I looked at this under a blood film and it's almost all neutrophils. When we see this, our concern more is that there's something inflammatory going on with our patient rather than necessarily a leukemia. When we have an inflammatory response, the first thing that happens is our peripheral neutrophils move to that area and attack whatever needs attacking. If that continues and if that inflammation is severe enough cytokines are produced. I said it, cytokines. Enough cytokines are produced that they go up to the bone marrow and stimulate bone marrow production. Okay, the first thing that happens is like any storage pools that we have get dumped out first because the bone marrow is pretty smart. It keeps a bunch of spare mature neutrophils up there just in case of emergency. They're the first thing to go out into circulation they go. Cytokines will stimulate the early parts of proliferation and drive the bone marrow to speed up its response. So, like, hurry up, we need more. And it'll start releasing neutrophils earlier and at younger stages. So, we get two things that end up coming out into circulation. One, we get banned neutrophils or even metamyelocytes. And in really severe forms, it like can go back to earlier precursors even. And then the second thing that happens is that we end up with toxic change. And toxic change is basically what happens when the bone marrow doesn't have enough time to make everything pretty. It's pretty much good enough, get out there, okay? So what are the big features of toxic change? Just a quick review off our list. Dolly bodies, increase in numbers of Dolly bodies, remembering that cats can have some normally. Basophilia, so that cytoplasm starts turning a little more blue. All the RNA in the cells are picking up that blue stain. So they start turning a little more blue, and we may start seeing vacuoles on them, and they kind of look like foamy, dish soap vacuolation to these neutrophils. So for example, I have one here that looks fairly toxic. We can see that this guy has pretty basophilia, some vacuolation. You may or may not see the Dolly bodies if it's severe enough in these guys. Just as a side note, any toxic change in horses is significant. Horses as a whole tend to have really nice, healthy neutrophils, and if we see toxic change in them, it's alarming. So anything, even like subtle Dolly body development in those. The thing with toxic neutrophils is that if the inflammation is severe enough and it's been going on long enough, it can be really hard to distinguish the neutrophils, especially ones that are like bands that having that C shape to them, or even metamyelocytes. It can be really difficult to distinguish them from monocytes. And that's something that takes a lot of practice and looking at a gazillion blood films to hone that particular skill. Okay, so if it's really severe inflammation, you're looking at it, you're just not sure. You're going to be sending out to a pathologist and waiting for that path report getting back. In most cases of those cases, you're going to have other evidence of inflammation that's going to be driving your diagnostic pathway down that route. Neutrophilias or even neutropenias, especially in some of our larger animals. Degenerative left shifts where there's more of the youngsters out there than the mature ones, very sick patient in front of you, febrile, all the signs of inflammation. So if you're looking at that blood film and you're like, God, these guys look really sick, it supports your diagnosis of inflammation. If inflammation has been going on long enough and the bone marrow has had time to respond and has upregulated to meet the peripheral demands, we will start seeing what we call a leukemoid response. And why leukemoid? Leukemoid says it's like leukemia-like. These are neutrophil counts that are starting to push 70, 80, 90, 100,000. It indicates that there's been inflammation cooking somewhere for some time. The classic example of this is canine pyometra, especially closed ones, where we've essentially have this trapped sac of pus that has been recruiting neutrophils for quite some time. And in these particular cases, if it's been cooking long enough, the bone marrow has been responding and we start getting these really high white cell counts. Now we can have pyometras that haven't been cooking long enough to reach that leukemoid response, but it's sort of one of the classic examples that we will give. The other time I have seen this sort of thing from an inflammatory response has been in immune-mediated hemolytic anemia. And not your classic ones that come in super sick with kind of an acute onset. I'm talking about the ones that are these kind of low-grade IMHAs that have been smoldering for a while, really been cooking. I've seen some impressive white cell counts with those as well. So one of the first things that we think of when we get these leukemoid responses and they start moving up there, even though we're using the term leukemoid, is that we want to make sure that there's no inflammation going on in this patient. That's the first thing that we're going to be ruling out with these guys. We back into weird stuff where we get really high levels of white cell counts in mature neutrophils, and the weird disease being a chronic granulocytic leukemia that sows neutrophils. How often do we see those? Like, hardly ever. You may catch them in practice from time to time, but it's very much a diagnosis of exclusion. You have to like rule out all inflammation. So before we give any patient cancer, let's make sure it's not inflammation. What about when neutrophils look like bands or even metamyelocytes, and that's all you see on your blood film, but you've got a healthy animal? So once in a blue moon, you may come across a patient with Pelger-Hewitt anomaly, and this is a genetic defect that basically prevents neutrophils from fully segmenting. And what you will see on your blood film is bands and maybe metamyelocytes. The interesting part of this whole Pelger-Hewitt thing is that the eosinophils, as well as the basophils, though we don't really see them out there, but the eosinophils will also have poorly segmented nuclei. Our classical breed for Pelger-Hewitt is the Australian Shepherd in dogs. With that said, it can happen across many breeds. In dogs, I've seen it in cats. It is definitely in people. So it can show up. It's something to sort of keep in the back of your cranium, and don't be fooled. Don't be fooled. These are nice, mature, healthy looking neutrophils. Their chromatin super condensed like they would be in segmented neutrophils that are nice and mature. They just haven't segmented. So this patient doesn't have massive inflammation. They'll present healthy. You'll be like, piece is not adding up. And that's when we sort of think, is this Pelger-Hewitt? When you have one of these cases, send it off with a detailed history for a path review. We're trained to look at this stuff, so we can help. So what if it's not neutrophils? Are they another white cell? Like fairly normal white cell. For example, eosinophilia. Thinking about parasitism, skin disease, pulmonary disease, GI disease, all that fun stuff that goes along with eosinophils. Rarely something like paraneoplastic. Classically, mast cell tumors, lymphomas, occasional carcinomas. Another thing these guys could be are nucleated red blood cells. Typically, we see these guys out in circulation when there's a regenerative anemia present. So look at the cells around. Polychromatophils. Does it look regenerative? Is this patient massively anemic, et cetera, et cetera? That's sort of the first thought for those. And we call that an appropriate metarubicytosis, an appropriate response when we expect to see it. They can be out there for other reasons. I see it with like heat stroke. We see it with lead toxicity, sometimes splenic contraction, all sorts of different things that can potentially cause it. Also including but not limited to our bone marrow diseases, bone marrow dysplasia, and all sorts of stuff. So just like anything, check in with your clinical pathologist and make sure that it's appropriate. Are they blasts? You've got those round cells, round nuclei looking at you, okay? That's when you're going to be definitely sending it off to a clinical pathologist to review and confirm. There's probably going to need to be additional diagnostic testing to figure out what they are. Provide a detailed history in case it's a stage 5 lymphoma versus a leukemia. Okay, so not neutrophils. Is it recognizable and you're comfortable going forward? Go get them, tiger. If it's not recognizable, make sure you use us. Ask for a path review and send us as much like history and detail as you can alongside with that CBC. The more knowledge we have of what you're seeing in your case, the farther we can take our interpretation and the more we can help you. So there we go. Let's wrap up our white blood cells. What have we reviewed today? So we've reviewed neutrophil morphology. We've talked about bands and metamyelocytes, and we've talked about how when inflammation is more acute and driving that white blood cell response, that they can sometimes have evidence of toxic change, increase in Dully bodies, basophilia, foamy cytoplasm. Patient not sick and looking inflammatory, but has a bunch of youngsters out in circulation. Think about Pelger-Hewitt, send it off to your clinical pathologist with a detailed history. What about long-standing inflammation where you start getting marked neutrophilias that start approaching that leukemoid range? You want to make sure you're ruling out all things inflammation before landing on something like a chronic granulocytic leukemia, which is a diagnosis of exclusion. Make sure you utilize your clinical pathologist, send off a detailed history. Okay, here we are on the other side of all of this. Let's sort of review our journey, where we've been today. So the first thing, and what I hope is going through your mind, is some enthusiasm towards utilizing blood films. And the first thing we need to do that is to train ourselves how to make them. So throw yourself a blood film training party. Woohoo! Blood film party! We've made friends once again with platelets in terms of looking for clumps and how to do a quick and dirty estimate as you're looking, trying to evaluate thrombocytopenia. We have reviewed our erythrocytes and what we look for in a regenerative anemia, including our polychromatophils. And then we touched on some of our hot topics, which are spheres, schistocytes, as well as our Heinz bodies, eccentrocytes, oxidative change. In white cells, our theme was to neutrophil or not to neutrophil, and how to sort of approach it, your discussions with clients, and going forward from there. Stuff that you're going to need on that daily basis to intervene more quickly. Don't forget to use us. That's what we're here for. And we are honored to be part of your team. It's my hope that you have found this review helpful and practical, and that you can start implementing some of these things and getting your skills up. So I appreciate you taking this journey with me, and I am looking forward to your questions and your feedback. All right. Thanks, guys. You know you're a clinical pathologist when you start to personally identify with certain red cell morphologies.